Hello, I'm Parsa Mohri, and this is Raise the Line from Osmosis and Elsevier, our ongoing exploration of how to improve health and healthcare. Today, we're continuing our NextGen Journeys series, highlighting learners and early career healthcare professionals around the world and their fresh perspectives on education, medicine, and the future of care. Today, we have Madison. Madison Donnelly is a women's health physician assistant, known in some settings as a physician associate, based in Albany, New York. She graduated with a master's in PA studies from Hofstra University in 2024, having received the Overall Achievement Award and Honors Jurisdiction at that time. While she was in PA school, she also served as a Challenge Bowl team captain for her program, competing at both state and national level. She also was a member of the Osmosis Health Leadership Initiative, or the OLLI program, where she later became a regional lead in 2024. Before venturing into women's health, she worked in family medicine, where she further mastered her clinical skills, treated patients of all ages and stages, and learned value of teamwork. Madison has a passion for caring for the most vulnerable populations, including the former NICU babies, domestic violence victims, and eating disorder patients. When she's not working, she can be found knitting baby blankets for her charity and baking up a storm in her kitchen, or watching reruns of medical TV dramas. So without further ado, Madison, thank you so much for being here.
Thank you so much for having me, Parsa. It's truly an honor.
To begin with, especially for our audience who may be from a country where the concept of a physician associate has not been yet integrated into their healthcare system, could you sort of run us through what it's like being a PA, mainly in terms of describing some of the common daily commitments that a PA would be pursuing in their own setting?
Yeah, absolutely. So just some terminology aside, physician assistant, physician associate, and PA generally all refer to the same profession. Some states in the United States have decided to change the name to physician associate, whereas traditionally physician assistant. I practice in the state of New York. That hasn't made that change yet. So in my position, I'm a physician assistant. However, I usually just tell my patients to call me a PA. My daily routines is kind of similar to that of my other advanced care providers. So think your nurse practitioners, your nurse anesthetists, or your midwives. I see patients on a regular basis. I am a provider of primary care to these patients. And really what my job is to help provide healthcare in settings where it is most needed and where there is a high demand for physicians or other clinicians, but there may not be the same supply, if that makes sense. So a lot of us PAs will work in general surgery, women's health, primary care, but we're not just limited to those fields. In fact, one of my very good friends actually works specifically with women who suffer from postpartum depression and postpartum anxiety, and that is their primary role.
Wow, that's quite a niche and specialized. I like how they're approaching a genuine issue that is very prominent within those populations. But like you said, sometimes there's just not enough healthcare workers or doctors to attend them, and that's pretty interesting to hear. I was wondering, what inspired you to pursue becoming a PA?
So it's actually quite a funny story. I was the kind of little girl who loved playing with her doctor set more than her Barbies, to the point of which to this day on my desk is my Dr. Donnelly pin from my first medical set. But I come from a family where healthcare wasn't really a career choice. Nobody in my family had ever pursued a healthcare career, not even as a nurse. So when I started really getting into science and learning, I had a very, very smart science teacher in middle school. Her name was Mrs. Antonescu, and she was a former radiologist who retired to become a science teacher. And I basically owe most of my medical career to her, because she was the one who really saw that not only did I love learning science, but I was also pretty good at it. And really part of the reason why I became a PA was just because access to care is super important to me. I think that all patients deserve care and all people deserve care. And seeing how I could provide the best care possible to as many people as possible, that PA position really inspired me. And also, I'm the kind of girl who's not big on making decisions. I like being able to use different skill sets. And the PA position has this wonderful concept of lateral mobility, meaning that my training is generalized. So I can move from family medicine to women's health to whatever else my career may bring without any extra medical training associated with it, except for on-the-job training.
That's pretty interesting. So you have, what was it called? Lateral?
We call it lateral mobility, similar to how like a factory line, if you're talking about having vertical mobility in a business, meaning you own the process from start to finish, versus lateral mobility, meaning you have control of all one level, whether that be distribution or production or concept creation. PAs have this really cool generalized education process of learning about medicine so that we're able to switch professional careers in terms of being able to move from specialties to specialty without needing any major severe training. Think more of a residency path when I say that.
I see. And right now, could you sort of describe your current work environment and what are your thoughts on it? Does it require you to, have that lateral mobility as well, or is it more fixed?
Yeah, my current work environment, I see patients who have what we've considered sexually female reproductive tracts. So think your pregnant women, people who are assigned female at birth. So a lot of my day-to-day work, I'm doing gynecologic routine exams. If somebody needs to have a breast exam for a problem visit or routine visit, as well as doing a lot of obstetric care, whether that be doing a membrane sweep, putting in an IUD, making sure that baby is flipping from breech to vertex position at that normal 32-week mark. So I do a lot of different things, but it's in a field that I love and it's doing things that I love. So part of what makes my position very, very cool is I work alongside two other providers who are NPs, but they are absolutely incredible. And we have 3 MD doctors with us as well. So we are a very strong team, and it's just wonderful to be able to work with people who have the same passion for women's health that I do.
That's incredible. I would never touch those procedures out of fear because they're very specialized procedures.
Yes, definitely. If it's more than just checking for an ultrasound for an ECV, I usually call in some backup, but even doing IUDs on a regular basis, it's one of those things where it amazes me every day that I get to do that.
Yeah, that's really incredible. And so we touched base a bit about women's health, and that makes me wonder if you've noticed any common trend that you see lacking regarding women's health. Could be within healthcare, could be within US or maybe another healthcare culture in another country, or whatever comes to your mind about that.
Yeah, I'll touch base on the US just because when we talk about women's healthcare in the US, there is some pretty alarming data out there, specifically when it comes to maternal morbidity and mortality, focusing on any conditions or deaths associated with childbirth and up to a year after. These, even though the US spends the largest amount of money in the world on healthcare, our numbers don't match up when that comes to maternal health. We still have rates that are way too high, especially for people who have been marginalized historically, people of color, people of low socioeconomic status. So one thing that I've really noticed in my practice, at the very least, is that when I see a patient from one of these backgrounds historically, I always make sure to express to them that they will always be heard. They will always be cared for by me. And as soon as something comes up, it is super duper important that they not only tell someone, but make sure that they are heard. And I really emphasize that there's a difference between telling someone something and being heard, which I don't think a lot of healthcare practitioners necessarily realize, that
absolutely
women tend to be dismissed for symptoms far, far, far more often than they should be. It should not take 8 years for the average woman to get an endometriosis diagnosis. And unfortunately,
Wow.
that's still the case. So I always tell my patients that the second that something comes up, even if it's just as simple as a medication question of, hey, should I be taking this? They know that they should be comfortable calling me.
That's wonderful. We definitely have this issue within the healthcare system where we like to pretend it's in the past because we talk about it now, especially when we say, like, yeah, in the past, research used to be only on 70-kilo male. And usually that result is extrapolated onto people who are born as a female, and the physiology and the results don't necessarily match. And as well, like you said, 8 years, I did not know that.
Yeah. And what's even more scary, just from my background, not only were period products for women not tested for a large majority of years, they weren't actually tested with anything resembling blood until 2023.
Wow.
They were tested with water or dyed water. That was one of the things where you find that out as a women's healthcare provider and you are just floored.
Continues to prove that as much as we like to admit this is in the past, it's absolutely not in the past. Well, thank you for sharing that. I'm sure it's been an eye-opener for our audience, just hearing a bit about the differences that's happening on a daily basis, even in developing or developed countries, sadly. So, in your experience, how have you seen vulnerable populations usually receive care so far? So we talked a bit about how they're usually just told what to do rather than feel heard.
I'll go back to one of my roots, which is talking about neonatal ICU babies or NICU babies, which is a little bit of a past gen of mine. Kids who tend to be born premature, definitely we as healthcare providers, we have a very good background in that of, okay, we need to make sure this kiddo gets the nutrients that they need. We need to make sure that they're growing correctly, that kind of stuff. One of my passions about it is what happens to those kiddos when they leave the hospital? Sometimes they fall off the map, healthcare-wise. And I've seen this one too many times where kiddos don't reach the milestones or end up with what we call failure to thrive. And it is especially heartbreaking when the parents of NICU babies also don't get any attention or care that they deserve. It is one of the populations that has the highest rates of undertreated PTSD and depression. I have seen many parents go through entire panic attacks in the neonatal ICU or completely dissociate just because of what is going on with that. So one thing that I tried to do as a student with all of my neonatal parents was just ask them how they were doing. Not even just like talk to them about baby. Ask mom, how are you doing? Because not often enough are we focusing on parents that we are having people slip through the cracks with untreated depression, untreated anxiety, and potentially, in very severe cases, untreated psychoses. It is one of those things where standard in OBGYN is to do a 6-week postpartum check, and that is all, with the exception of a C-section, which you check the wound at 2 weeks, then 6 weeks.
Yeah, it doesn't really seem like a holistic approach.
No, it's very, very, I call it backwards in my world, where the good news is that there have been new pharmaceutical interventions to try to help these parents with postpartum depression, anxiety, etc. But my fear is always that we're not going to catch everybody. And one of the things that while I was in primary care, I really emphasized was that every new parent should at least be screened twice for postpartum mental health issues, including the fathers, because they can get it just as much as moms, and that we can potentially help more people in our community. It's one of those things where mental health was never really talked about until the 21st century. Within a positive light, it was always, there's something wrong with you, what are you talking about, etc. And now that we know about it, it's one of those things where we really need to bust open that door or we're going to still have a lot of people left in the dark.
Very well said. And even though it's been given some recognition, at least in practice, I've noticed how, yes, there are questionnaires that's taught but never used. Like, it's just there, like, made with very nice intentions, but for some reason, it's like, yeah, not needed to do, not enough time. And that's where I think things start to slip through the cracks, as you have said.
I remember probably my second week as a PA, I had a new parent come in with just raging postpartum depression. And I went to my supervising physician at the time and said, "Oh, would you keep the Edinburgh scale?" Which, for those who don't know, is the scale we use for postpartum depression. And her response was, "What's that?" My response was, "What do you mean, what's that?" So needless to say, I made sure that we had copies of said scale throughout the office just to make sure that we were aware of it. And my MAs were phenomenal in that they knew that anybody who is at minimum a year postpartum would get these scales as well.
Well, thank you for spreading this awareness right now to the podcast episode. And as well, I mean, that was actually interesting for me to learn and to be able to encourage, I think, such practices, especially in such a well-needed environment. I was wondering, do you have a moment, if it was not spoken of already, that is from your own patient or caregiver experience that has sort of reshaped your path or ethics in practice? So you've definitely mentioned some very great cases, and I wonder if there's anything else that you would want to share.
Yeah, I won't say what institution this happened at just because of issues with said institution, but I will say this was a moment that definitely broke my heart in more ways than one. I had been treating a few different patients with eating disorders, which is another passion of mine, in that we grow up in a society here in the US that is very diet-centric and thin-centric, so much so that it's estimated that around 30 million US adults will have an eating disorder at some point in their life.
How much did you say?
30 million.
Oh my God.
And that's an underestimate. That's just what is clinically diagnosed. Most of these cases do not get clinically diagnosed, which is why I say it's an underestimate, but it is a large population. And I remember, very clear as day, I was in a conference room with a few junior residents, and we were talking about our patients, just going over like, okay, who needs their NG tube flushed? Who needs an NG tube? Who is eating appropriately? Who needs to be up on calories? That kind of stuff. And one of the residents goes, "Well, they really like their NG tubes. They're just all type A wannabes. Why are we even treating these?"
That's quite upsetting of a comment to hear, to be honest.
At that time, I was still very much involved within eating disorder awareness circles and very much involved in that setting, which they did not know at that time, and I made them aware of shortly after. But one of the things that I tell all of my patients is, I do not care what weight you are at when you walk in my door. When you walk in my door, I want to make sure that you are eating, you are drinking, you are sleeping, and that your mental health is stable. Those are my 4 goals. If that means that you're at a weight that is heavier than what society deems to be appropriate, that's fine. It's just a matter of your health for me. If you're at a weight that society says is okay, great. If not, that's fine. I always tell people that I would rather you be at your happiest mentally and at your healthiest physically, even if that number on the scale might not be the number that you think it is, or the number that you might want it to be. We as a society need to, and we as a medical society need to move away from treating a thin ideal as the absolute perfect ideal to go for before more people get hurt and before this becomes more deadly than it already is. It's already the second most common cause of death is anorexia nervosa when we're talking about people who die from mental illness. It doesn't need to go back to number 1. It was only taken over a few years ago by opioid use disorder.
That is shocking to hear. I did not know it was the second most.
Yeah, I believe it was 2021 or 2022. It flipped to number 2. But for a solid 20 to 30 years prior, it was number 1.
How upsetting, especially when it seems like there are still, how to put it, like one may call it an encouragement of, yeah, like you need to reach this goal, whether it's like optimal health, but then it's created this sort of toxicity of trying to overachieve. Maybe, yes, cut down on weight, but not to the point where you have anorexia, for example, or where you stop eating and you have electrolyte imbalances. Yeah. And it's incredible.
There's also, I have caught a number of patients who would be very, very adamant that they need a GLP-1, come in with a BMI of 23 and tell me that they absolutely need a GLP-1. There's no way they're leaving my office without one. And I'll screen them for an eating disorder and it come back blatantly positive. I've seen that way too many times. So this isn't a problem that's going to go away anytime soon.
So I'm sure the audience has come across with the rapid advancements of artificial intelligence, AI in healthcare, or everywhere. Which cases would you say you're the most optimistic about, as well, if there's any aspects that concerns you?
Yeah, I think there's both good and bad in AI technology, as there is with most kinds of technology. I was of the age of PA school when AI really started to become big. So I've seen it used in simulations a lot. And I have to say, simulation is probably my favorite way of using AI. I've seen many cases where they get the most realistic kind of answers, or you get patient answers that are not exactly these textbook answers that you expect. So in that aspect, I love it because you get to see all these different things and you get more realistic answers. You're not getting somebody who tells you exactly where your pain is with AI. They could be like, oh, I don't know. Maybe it's here, but maybe it's here, but maybe it's here also. And that is a real patient experience, right? So I love that part of it. The part of it that worries me a tiny bit is, do we become too dependent on it? And I think that's with all technology, right? We have this social media generation of kids who we're realizing, well, maybe we need to step back a little bit with social media on. So do I think we're going to reach a point of AI potentially being overused? Eventually, yes. But it's important that we continue to develop this technology so that when we do use it, it's for the benefit of us and not for our detriment.
As a quick note, I've also used the simulation with patient communication for giving news, especially the spikes protocol.
Oh, not the spikes protocol. The good news was my school had actual standardized patients for the spikes protocol. That was one that they made us do it in front of a real person, and I appreciate that. But
that's nice. So with your time being within the Osmosis community, the Authy program, what sort of content gaps do you see within their offerings? And which sort of topics would you love for us to cover next?
You guys, I have to say, Osmosis is really, really wonderful in terms of providing content that's not only medically relevant, but it's also very inclusive of a lot of populations. I loved how you did the Year of the Zebra content, talking about rare diseases, especially coming from a neonatal background of we see all these all the time. It's nice to have that in there as well. One thing that I noted when I first started using Osmosis was that there were a lot of conditions where it was like, I want to know more about this subtype or this subtype. And you guys have really done a really good job at making sure that that content gets expanded on. You're like, oh, you want to learn more about this cardiomyopathy? Sure, here's a whole video on that. And I really loved when you guys launched that clinical series in terms of clinical sciences for us as physician associates. It was really cool to integrate not only a little bit more about management, but how to work something up, how to stabilize your patient. It was really, really cool.
Yeah, that's nice to hear. I never really appreciated it until I went to clinical years myself.
Yeah, it's one of those things where you don't really necessarily, if you're like, oh, why am I going to use this? And then you go to clinicals and you're like, oh, there it is.
It's like, I know how to do that. But then when you're actually seeing it, you're like, wait, actually, I need to open that Osmosis video.
You're like, what do I do? Well, first, make sure they have a pulse. That's probably a good thing.
Yes. We had some great conversations today, and I was wondering what's one thing you would like our listeners to take away from this episode?
I think if there's one thing, it's that every person deserves kindness, dignity, and respect, regardless of what their medical situation is. It's one of those things where it doesn't cost anything to be kind. And it doesn't cost anything to listen with all of your heart and your head and your ears. I think far too often in healthcare, we focus on the negatives, focus on trying to get every patient seen within a certain period of time, making sure that all of our charting's up to date and that kind of stuff. And I think far too often we are letting that kind of take over our humanity and our emotions in terms of connecting with patients, making sure that they feel seen and heard by the time they visit that office. I always say that you never know when somebody's worst day is or their best day. It's your responsibility as a provider, as a clinician, to make sure that it wasn't the worst day of their life because of you. Or if it was the best day of your life, it wasn't a dark spot on that day.
Very, very well said. I think sometimes we do tend to get hyper-focused and forget the humanity aspect of connecting with the patients rather than just treating them. Well, thank you very much, Madison, for being with us today.
Thank you so much. It was an honor. And can I give a few shout outs to my clinical team before I leave?
Absolutely.
Okay. So I have a few shout outs to give. First one is going to be to my partners at Community Care, Obstetrics, and Gynecology. Thank you so much for everything. I love you dearly. I also have to shout out a few of my professors from PA school who I'm still in touch with. So Dr. Will Heuser and Dr. Gina Bontrelli. Thank you for everything. I truly am so grateful to know you. As well as two colleagues of mine, which is Kelsey McCullough and Colleen Petrari, who've both taught me so much in so many different aspects. So they made me who I am today.
That's awesome to hear. Thank you for the shout outs, Madison.
Of course. Thank you.
I'm Parsa Mohri. Thank you for checking out today's show, and remember to do your part to raise the line and strengthen the healthcare system. We're all in this together.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelinepodcast.